Hello, and welcome to this virtual presentation on the impact of health literacy on diabetes outcomes. My name is Kimberly Dykes. I am a Doctor of Nursing Practice student at the University of South Alabama and currently serve as a Master's Prepared Family Nurse Practitioner in a rural health clinic in Northwest Florida. This presentation is a short representation of my doctoral quality improvement project. I would like to thank my faculty advisor, Dr. Nancy Turnham, and my clinical preceptor, Dr. Stephen Spence, for their selfless investments in my educational endeavors and for their contributions to this quality improvement project. The American lifestyle has morphed over the course of the last several decades into a high-calorie consumption, low-calorie expenditure pattern. The result has been a drastic increase in the prevalence of obesity, leading directly to an increase in the prevalence of type 2 diabetes. According to the American Diabetes Association, more than 9% of the American population has diabetes, and nearly 2 million more are diagnosed every year. When uncontrolled, diabetes causes an endless list of complications, the most prevalent of which are heart attacks, strokes, kidney failure, blindness, and amputations. The disease is the seventh leading cause of death in the nation and accounts for an estimated $245 billion in healthcare spending annually. The most disturbing fact of all, diabetes complications are preventable. With proper diet, exercise, and medication adherence, individuals with diabetes are capable of living full, long, and healthy lives. What's more, many cases of type 2 diabetes are curable with proper diet, exercise, and weight loss. Background. Knowledge is power. One cannot put into action what one does not know. It was hypothesized that improving the health literacy of patients with diabetes would lead to improvement in measurable diabetes outcomes. Hemoglobin A1C, low-density lipoprotein, and body mass index are known to correlate with long-term diabetes outcomes. The purpose of this quality improvement project was to provide diabetes education to diabetic patients demonstrating knowledge deficits and measure the effects of this intervention on the previously mentioned measurable outcomes. As healthcare providers, nurse practitioners have a duty to provide the highest quality of care to every patient at every encounter. Quality of care goes beyond evidence-based prescribing patterns. After all, medications alone cannot fix every problem. Type 2 diabetes is a prime example of this statement. The goals of the Quality Improvement Project revolved around patient engagement. The focus was on identifying knowledge deficits and reconciling them with the ultimate goal of improving measurable endpoints. Methods. 20 participants were recruited for the study. Prior to approaching the patients about participation, their charts were reviewed to ensure that they had a minimum 3-year history of type 2 diabetes, were 18 years of age or older, and spoke English as a first language. Once recruited, the patients were randomized to either the control group receiving the usual treatment or the intervention group, which was referred for diabetes self-management education. As previously mentioned, the study setting was a rural health clinic in Northwest Florida. Participants in the intervention group were referred to a free diabetes self-management education program at the local hospital. Valid and reliable tools are an integral part of any research or quality improvement activity. Identification of diabetes-related knowledge deficits was achieved through utilization of the Michigan Brief Diabetes Knowledge Test. This valid and reliable 23-question multiple-choice test was administered to all 20 participants at the beginning of the study, as well as at their 3 to 4 month follow-up visits. Analysis of collected data was performed using the statistical package for social science. The start of the intervention and data collection phase is marked by initial administration of the Michigan Brief Diabetes Knowledge Test. In addition to recording these test scores, current hemoglobin A1C, body mass index, and low-density lipoprotein measurements were obtained for each participant. The usual care, intra-visit brief diabetes education, was provided to all 20 participants. The intervention group was then referred to the free diabetes self-management education program at the local hospital. Each participant was followed up 3 to 4 months later for the usual 3 to 4 month office visit. Participants were reassessed using the Michigan Brief Diabetes Knowledge Test, and new measurements were taken for hemoglobin A1C, body mass index, and low-density lipoproteins. Data analysis was performed using the statistical package for social science. Descriptive statistics were used to calculate means for all of the variables. Since baseline measures differed between the groups, percent change for each variable was used for more accurate comparison. The Mann-Whitney U-test was used to define percent change differences between the control and intervention groups. Spearman's rho was used to define statistically significant relationships between the independent and dependent variables. Results. Data analysis demonstrated a greater reduction in hemoglobin A1C values among those referred for diabetes self-management education when compared to the control group. Further analysis using Spearman's rho confirmed that the correlation between hemoglobin A1C reduction and diabetes self-management education was statistically significant. The same analysis was repeated for LDL, and BMI, finding the same statistically significant correlations. Although improvements in the Michigan Brief Diabetes Knowledge test scores were greater in the intervention group, there was not found to be a statistically significant correlation between percent change in test scores and referral for diabetes self-management education. Application of the Mann-Whitney U-test confirmed the reliability of the previously discussed correlations. Specifically, there was a statistically significant difference in the mean A1C percent change, mean BMI percent change, and mean LDL percent change between the two groups. However, there was not a significant difference in the percent change of the diabetes knowledge test scores between the two groups. Discussion. The results of the Quality Improvement Project indicate that diabetes self-management education can have a significant impact on diabetes outcomes. This finding is in keeping with current literature that improved diabetes health literacy results in cost savings by reducing diabetes-related complications. The literature goes on to point out that there is little evidence to indicate that healthcare providers facilitate consistent, ongoing diabetes self-management education. Moreover, additional studies are needed to characterize the long-term effects of consistent diabetes self-management education on diabetes outcomes. Moving diabetes into a self-management direction amongst a more health-literate population is imperative. Healthcare providers must empower patients with the tools that they need to effectively engage in self-care. Since healthcare providers cannot go home with their patients and make daily decisions for them, the burden of the battle against morbidity and mortality must shift into a first-person defense plan. Only then will healthcare delivery reach the highest quality possible.